Rossio, Director of Business Development with Joliet Area Community Hospice. And today I have our medical director with me, Dr. Crod. Welcome, Dr. Crod.
Thank you for having me, Mary.
Yeah, thanks for sharing. You know, the idea of this series is really to reach out to you, the physician, and I really was excited about the idea of physicians talking to physicians, so it's more relatable. Dr. Crod has years of experience as a hospitalist, so I'm really wanting to focus this conversation as into maybe who's eligible or would meet criteria for the patients that you're seeing in the hospital when you're rounding. Those may be patients that you're familiar with, you've been seeing them for years, or in the hospital sense, it may just be a patient you're seeing for the very first time. So Dr. Crod, tell me a little bit about if it is a patient that they're not that familiar with and they're seeing them, what are some of the things that they could really look for to see if hospice is the answer for them at that time?
Yeah. Again, you know, I have experience as a hospitalist in many hospitals in the Chicagoland area. And one of the things I've noticed and I've come across myself and with fellow physicians is we have a lot of patients that are getting close to the end of their life. Unfortunately, we can't provide the services they need and they benefit from that hospice can offer. So sometimes it's hard to engage in that conversation about the end of life, and there's a lot of signs right there in front of us that they could benefit from hospice. We see patients all the time that get readmitted to the hospital.
Yes.
And sometimes those readmissions can be avoided and better care can be offered to the patient. We have patients, unfortunately, in hospice. Hospice is, as we all know, is basically a service provided to patients who are expected to live less than 6 months if the disease were to take its normal course. And unfortunately, most referrals to hospice are actually in the final 3 weeks of their life rather than the final 6 months of their life. So these patients, unfortunately, and their families miss out on end-of-life spiritual support, psychosocial support, emotional support, and end-of-life planning and quality time together to focus, you know, on those end-of-life needs. And that's often because they're referred to hospice a little bit too late. And unfortunately, in the hospital, I'd say it's even unfortunately worse because we're so used to thinking, especially as hospital physicians, hospital nurses, where we often refer to hospice when somebody's actively dying rather than when they're approaching the end of their life.
Or diagnosed with a terminal illness.
Exactly. So a lot of times we think of somebody, for instance, say cancer. Somebody has metastatic cancer and it's spread all over, and they've tried everything. They've tried chemotherapy, radiation, immunotherapy, and despite everything, they've had recurrent hospitalizations, and now they're actively dying from that cancer. Maybe we'll consult hospice right now. So the reality is, terminal illnesses, not just cancer, but you know, advanced lung disease, advanced heart disease, you know, neurologic conditions such as ALS or a stroke.
And we are seeing a lot more of ALS patients as.
Yes, we are. And a lot of these patients have a little bit more education on what to expect when they're brought onto hospice, you know, sooner rather than when now they're on a ventilator and they have a tracheostomy and it's not really hospice, but it's withdrawal of care. So we want to not withdraw care, but we want to add and give care at the end of life. And part of that care is not just physical medical care, but it's, again, that emotional, psychosocial, and spiritual support that patients need and families need too. So again, you know, I think things to look out for, you know, as a physician, and reasons to engage and initiate a conversation sooner. Sometimes, you know, myself included, it's, you know, we're all pressed for time, and it's a time-consuming and sometimes it's just a hard conversation just because we're not used to it. But it's a time-consuming and difficult conversation to have with patients that a lot of time doctors and nurses unfortunately avoid that conversation about the end of life and goals of care. And you know, and sometimes that's really what patients want. Sometimes, you know, a lot of times patients are in tune with their mortality, they know they're dying, and unfortunately, you know, as providers, we don't, you know, help them engage in that conversation. You know, sometimes we can give them more closure, we can give them more peace by initiating that conversation sooner. And, you know, none of us want to fail that, but sometimes we do. And I believe that engaging in that conversation sooner gives them that quality time. It prevents recurrent admission after admission after admission, which is not just, you know, hard on the whole system, but it's very hard and taxing on the patient and the family. It's not a quality of life. And we know that as physicians, but oftentimes we don't talk about it. And engaging in that conversation sooner is what gives that patient quality of time for months at the end of their life, rather than just days, weeks, sometimes less. Oftentimes we don't get hospice involved until they're on a ventilator. You know, ICU is maxed out on so many pressors, you know, and they really just can't get somebody off a ventilator, and we're doing all these antibiotics, and we just know there's nothing else we can do. So now, you know, we have them on hospice just the final hours of life.
Right. And they
sometimes-
missed all of that opportunity to maybe die at home or have that comfort at home.
Yes,
Instead of making that third or fourth trip to the hospital,
yes.
we could have had that conversation at the second trip and potentially avoided that third or fourth trip.
Yes, for sure. Yeah. So, you know, and things to look out for, because sometimes it's easier said than done, but things to look out for, again, is that pattern of decline. So some things to look out for that a physician can see and note, and not just physician, but nursing staff at a hospital can see, again, is recurrent admissions for infections, recurrent admissions for pneumonia, multiple hospitalizations for pneumonia, UTIs, altered mental status. Other things that you see is, you know, recurrent loss of consciousness or decreased level of consciousness, significant weight loss and wasting away, or advanced and progressing pressure ulcers. Those are some things that show that there's a decline. Lack of nutritional status. We have patients all the time that come in with failed swallow studies, dysphagia, and that basically spirals into worsening nutrition, worse infections, and those are some signs that a patient is ready to initiate that end-of-life conversation and goals of care.
And we hear from our families a lot too that, you know, when they call 911 or they end up in the hospital, it's really out of panic. They don't know what else to do. Where if they already had hospice in place and that support system, they could have called us and we could have come to the home, whether it's an adjustment of medication with your guidance or help in that piece, we could have kept them in their home comfortably versus being in the ER, which in return gets you admitted to the floor to ICU.
Yeah, I couldn't agree more. And I think, you know, education is such an important part, and we need to engage in that conversation as physicians sooner, not just to educate the patients. I think, you know, we need to educate ourselves about it too. We have a notion and unfortunately a stigma that hospice is giving up.
Right.
It's a place where you die. And we think of it in a bad way, rather than let's celebrate your life, let's focus on increasing quality of life with family at the end of life. And I think people have this perception that if I'm in hospice, I have to give up. I can't do anything. I can't give any of my medications. I can do nothing but take morphine and Ativan and give myself medicine to get drowsy and just waste away and die. The reality is that happens in patients who are actively dying, and it gives us that false impression of what hospice is. You know, one's mother may have breast cancer and metastatic breast cancer, and she may be dying in, 5 months if the disease were to take its natural course. It doesn't mean she has to die of a urinary tract infection tomorrow. You can have a urinary infection and we could treat it as an outpatient. We can give antibiotics. We can treat it as an outpatient at home where she's comfortable and with her family, and give her that quality of life.
we have an opportunity to manage other things other than the diagnosis itself.
Yes.
Yeah.
Yes. And I think a lot of patients, don't know that because they're not educated on that. And we see a lot of patients who come into hospice and they say, wow, I wish I knew
Yeah,
about this
sooner.
sooner. I
Absolutely.
wish I could have done
Absolutely.
this sooner. I feel better in hospice. I'm having quality days, at the end of my life. And I'm enjoying those days and I'm enjoying those moments and I'm at peace with my life and where my life is headed.